On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Preparing for an Emerging Pathogen, Candida auris. My name is Joanne Atkins, and I will be your moderator for this program. Now, I would like to introduce our speaker for the webinar. Amanda Bennett is an infection preventionist for the Patient Safety Authority. In this role, she serves as a resource for Pennsylvania facilities through education and the development and monitoring of infection prevention and reduction initiatives. Ms. Bennett has an extensive background in infection prevention, laboratory testing, analysis and interpretation of diagnostic results, education, and regulatory standards. Amanda, I will now turn the program over to you.
Thank you, Joanne. So today we'll be talking about Candida auris, which is a fungus that currently presents a global health threat, especially in healthcare settings. It's imperative that facilities are aware of Candida auris and prepared if they have a patient who presents with an infection or colonization. It's not only important to know how to respond once you have a case through isolation and cleaning procedures, but also to know who is most at risk, how to identify a case, and then also limit the spread if you do have a case within your facility. The objectives for today's presentation are: explain Candida auris is important in healthcare facilities as an emerging pathogen, identify which patients are most at risk for Candida auris infection, recognize why Candida is hard to identify in the laboratory setting and how to create a plan to identify questionable specimens, apply surveillance, prevention, and isolation practices for Candida auris in the clinical setting, and then to evaluate appropriate disinfectants for environmental cleaning against Candida auris. So first, we want to start with a couple of questions here. You'll see the first poll question up, just to get an idea of what people's experiences with this organism, and then where you are in your plan for your facility. So while everyone's entering this answer, I just wanted to thank everyone for joining us today. I know that your time is important, and it's great for us to be able to get more information out into the field about this organism. This is a really important emergent pathogen, and the more you know, obviously, the better prepared you can be to help keep your patients, residents, and staff safe with this here. And we should be getting the results up relatively soon. I am guessing that we will not have many people who have seen it before, which is good. Okay, so yes, we have, out of 30 people who responded, 70% have not seen it, and we have 7 who have. So the good news is if you haven't seen it yet, hopefully after this webinar, you'll feel a little bit more prepared for what to do with it in your facility if you do see it. And our second question here that the poll just went up is, does your facility have a process in place to deal with Candida auris? And you'll see based on our questions, we're really kind of expecting a wide variety here, all the way to, yeah, you've got a policy, a process in place, and all of your staff are educated, down to that you have not started your discussions yet. Just know that there isn't a right answer here, even if your facility has no processes currently in place. We will try and get you, like I said, more prepared with the webinar today and give you a good place to start and a good to-do list of how to prepare and what to start thinking about within your facility. Let's see what we have here once these poll answers come through. Okay, so pretty spread evenly. It looks like the majority, 31%, do not have anything in place. It is good to see, though, that we have a lot of facilities that are somewhere in the process and have at least started the discussion. Okay. So we're going to start with just a very high level of what Candida auris is. Like I said before, it is an emerging yeast infection that has caused severe illness in hospitalized patients and has caused outbreaks in healthcare facilities. It can spread through contact with affected patients, but also through contaminated surfaces or equipment, and it can live on surfaces for several weeks. Data from a limited number of patients estimates that about 30 to 60% of people with Candida auris infections have died, while many of these patients do actually have other serious illnesses that increase their risk of death. When we're looking at C. auris as compared to other Candida species, there's some vital differences that we really see that are important to keep in mind. There was a quote from a journal article published in Pathogens and Disease by Vila that stated, while much remains unknown about the biology of C. auris, it has become quite evident that this new species is strikingly different from its close relatives in terms of its genetics, resilience, and pathogenic capabilities, to an extent that will change the way we think about Candida and Candida infections. I think this is a really important point to keep in mind throughout this presentation and when making your plans. Candida auris does not act like other Candida species we're used to seeing in the clinical setting, and we don't care for these patients and their infections in the same way. We need to be thinking about this pathogen more in the way we think of organisms like MRSA or CRE, and it's really important that we're able to effectively communicate this to our clinical staff as well. This is not the same as most of the yeast infections that they're used to seeing. In fact, in some areas of the world, the emergence of C. auris has changed candidemia epidemiology, such as areas like South Africa, where it's already outcompeted Candida albicans, which was previously the most common fungal pathogen. C. auris exhibits some specific features that make it unusually different from other Candida species, and these include its ability to persistently colonize the skin and environmental surfaces, the ability to resist common disinfectants, and that it can survive for weeks on surfaces. Important too is that it really has efficient person-to-person transmission, which is different from what we see in other Candida species. Usually with those, we see the species come from the individual's own microbiome and not necessarily a person-to-person transmission. Another thing to note is that it doesn't appear to actually colonize the GI tract, which is something we commonly think of with other Candida species. So looking at the history and the prevalence of Candida auris is pretty remarkable. It was first identified in Asia in 2009 from an ear canal infection from a patient in Japan. Subsequently, in 2015, it was reported from 15 specimens in South Korea. These were also ear specimens, but they were collected back in 2006 from 3 hospitals as part of a multi-center surveillance study of unusual yeast. These were originally misidentified as another Candida species. All the patients had chronic otitis media, 7 had persistently positive cultures, and 3 had received systemic antifungals. After this, reports of C. auris bloodstream infections started to emerge. There were 3 cases identified in South Korea from a retrospective microbiology review of unidentified yeast. One of these specimens was actually collected back in 1996, and this is now the first known occurrence of C. auris. The remaining 2 cases were collected in 2009. All 3 of these patients had hospital onset infections and had been in the hospital for at least 12 days prior to their cultures being collected. Then in 2015, we began to see it spreading to the United States. We know that 4 strains developed around the same time around the world, and that all 4 have been found in the United States. With increasing genome sequencing, recently there was an ear swab isolate recovered from a patient in Iran. And this indicated a 5th major clade, which is genetically distinct from the 4 existing clades. Genetic sequencing of isolates has shown that these clades differ by tens of thousands of single nucleotide polymorphisms, or SNPs, but within each clade, the isolates are almost clonal. So what this indicates to us is that C. auris emerged independently, but simultaneously in at least these 4 geographic locations. And as you can see from this map from the CDC, the strain first identified in northeastern U.S. in states like Connecticut, Maryland, New York, and New Jersey was a South Asian strain. But we did have some of those states see multiple strains. New York identified both the South Asian and the East Asian strains. It's likely that it was introduced through international travel and then spread in the U.S. healthcare facilities. to me, this was striking as it's the same we saw with COVID, and that it really showed up in New York first because there is so much international travel that comes through that state. Next, looking at the spread throughout the United States between 2013 and 2021, we're going to use these maps just as an overview to see the progression and the growth of Candida auris in the U.S. over these 9 years. The color key has changed in these maps over time as more cases appeared and targeted screening increased. In the most current map from 2021, all of the states with pale yellow have no reported cases. This is similar to the gray states in the previous years. It's also important to know here that these maps are not cumulative. They're based on reported cases for that calendar year. So some states may have reported cases one year and then not have anything reported for the next year. For example, Oklahoma had a case reported in both 2017 and 2018, but then did not have anything reported in 2019. So in that first map between 2013 and 2016, we had a total of 63 reported cases from 4 states. Doesn't look that bad, not that widely spreading. We seem to be doing okay. But then going all the way to last year in 2021, there was a total of 1,278 reported cases from 20 states and the District of Columbia. That is a 95% increase over 9 years. So it really spread fast and it spread wide throughout the United States in just that 9 years. So now I want to take a closer look at the most recent data from last year. In 2021, Pennsylvania reported 14 clinical cases. Nationally, like we talked about, the U.S. reported 1,278 clinical cases, but there was an additional 3,772 patients identified as colonized with Candida auris. When we talk about the definitions for both clinical cases and colonization or screening cases, they're established by the Council of State and Territorial Epidemiologists. And like definitions that we use for other infections as IPs, clinical cases are identified from diagnostic testing collected during the course of clinical care for the purpose of diagnosing or treating. Whereas colonization or screening cases are identified when swabs are collected to determine whether a patient may be carrying the organism somewhere on their body without signs of an active infection. This may be done in facilities when there is suspected transmission or colonization to help contain the spread of Candida auris. Now looking globally at the spread. This is from 2021. This resource from the CDC doesn't provide specific numbers of cases per country, but it does represent 47 countries reporting cases through February 15th of 2021. They have since stopped updating this map given how widespread C. auris has become. And when I tried to look up how many countries there are globally, this actually represents about 24% of countries in the world that have reported cases. So why is Candida auris so important in the healthcare setting? First, it's difficult to identify with standard laboratory methods, and it can be misidentified. It spreads easily between hospitalized patients and nursing home residents, and it's often multi-drug resistant, with some strains resistant to all 3 available classes of antifungals. 90% of isolates are found to be resistant to at least 1 antifungal, while 30% of isolates are resistant to at least 2 antifungals. For all of these reasons, Candida auris became nationally notifiable to the National Notifiable Disease Surveillance System, or NEDS, in 2018. C. auris's relevance is even more important with the current COVID-19 pandemic. COVID likely increases the risk for fungal infections because of its effect on the immune system and because treatments for COVID-19, such as steroids, can weaken the body's defenses against fungi. In the United States, we mostly saw C. auris spread in long-term care facilities in residents with severe medical conditions. Although during the pandemic, we've now seen more outbreaks reported in COVID-19 units in acute care hospitals. There could be multiple reasons for these outbreaks during the pandemic. Some of them include changes in our routine infection control practices. For example, when we had all that limited availability of gloves and gowns, and then to try and mitigate that, we saw people reusing or extended the use of these items. We also saw changes in cleaning and disinfectant practices. We also know that screening for Candida auris colonization is a really important part of containment efforts, but this has been much more limited as healthcare facilities and health departments have really been focused on COVID. To further enforce Candida auris is important as an emerging pathogen, it was added to the CDC's 2019 report of antibiotic resistance threats in the United States. Now, this didn't even show up on the previously reported report that came out in 2013. So it went from not being on the list at all to the complete top in the urgent threat category. So you can see here, like I said, it is in the highest category of urgent threats. And the report describes these as public health threats that require urgent and aggressive action. And just looking through this list really helped for me to put into perspective the importance of this pathogen, seeing it listed with other important organisms that we may be more used to looking out for in the clinical setting. Some virulence factors of C. auris are strain dependent, but there are some that are general across all the clades. Those factors are that it has enzymes such as phospholipases, proteinases, and secreted aspartic proteases. They also have adhesins, which allow it to more effectively attach to host cells, and it has an ability to form high-burden multi-layer biofilms. These biofilms are less robust than biofilms formed by Candida albicans, but it is important to know that it does have the ability to create those biofilms nonetheless. Interestingly, unlike other Candida species, it is unable to grow in an anaerobic environment. So who is at risk? As I mentioned at the beginning of this presentation, a lot of patients who acquire Candida auris have risk factors which make them more susceptible. These are similar risk factors that we find put patients at risk for a wide variety of infections. These include having a long stay at a hospital or a nursing home. Most patients in the United States with C. auris infections have had extensive exposure to healthcare in the month prior to infection, especially in facilities such as long-term acute care hospitals and skilled nursing facilities. Patients also with a central venous catheter or other lines or tubes entering their body. Patients who are colonized usually see candidemia occur after an event, like the placement of a new line or a tube. This happens because the yeast is given an opportunity to be introduced to the bloodstream via the skin. Having recently been on antibiotics or antifungal medications, almost half of patients with C. auris infections have been on antifungals at the time of their infection or immediately before their diagnosis. If a patient has had recent surgery or if they're diabetic, although interestingly, age does not seem to be a factor with Candida auris infections, as we have seen them in all age groups. Common types of infections that we've seen are the bloodstream infections, wound infections, and we have also seen isolates being recovered from respiratory and urine specimens, but it's not clear if it actually causes infections in the lung or the bladder. The yeast was first isolated from an ear canal, which is why it was given that name Candida auris, which is Latin for the word ear, although we now know it can infect many other sites. I apologize, I forgot to advance my slide there. Now we are back on track. So one of the first steps in preparing your facility is to communicate with your laboratory. It's important to confirm your laboratory can speciate for C. auris, and if not, what is your plan to speciate if necessary? You'll also need to identify a mechanism for infection prevention to be notified about possible or confirmed C. auris. And this is something that you're going to want to get regardless of the time or the day, because it's really important to get the patient or resident isolated immediately and ensure appropriate disinfectants are in place. Staff will need to be educated as well, assuming this will likely be the first time they've encountered Candida auris. Suspected isolates can also be sent to the CDC's AR lab network for identification and susceptibility testing. This can be performed free of charge, but it does need to be coordinated through the state public health department. Next, we're going to talk about the identification or the misidentification of Candida auris. I say misidentification because it can be misidentified as various organisms when using traditional yeast identification methods. This is because there are no phenotypic characteristics to easily distinguish this from other Candida species. It is an ovoid or elongate budding yeast which grows well at 40 to 42 degrees on chrome agar, and it can appear white, pink, red, or purple. The CDC currently recommends that all yeast isolates from a normally sterile site be identified to the species level. When Candida is identified from a non-sterile site, like urine or the lungs, it may represent colonization, which we don't really treat with antifungals, and so it doesn't necessarily make sense to identify it to the species level. Also, we have situations where clinicians might not find it necessary to speciate Candida specimens, even when they come from sterile sites, because they plan to treat all Candida with the same antifungals. But as we know, Candida auris is commonly multi-drug resistant, so this line of thinking can be problematic. Not identifying to the species level also leads to more cases going unrecognized. We know that in the United States, about half of clinical Candida auris cases have been identified from non-sterile sites. So if you're not speciating down to the species level, you would be missing a lot of those. The most reliable way to identify it is with matrix-assisted laser desorption ionization time of flight mass spectrometry. So instead of saying that mouthful every time you refer to this, you'll commonly hear it called the MALDI-TOF. But it must be included in the instrument's database, which is not always the default settings for this instrument. And then a clinical implication of all of this, with it being so difficult to diagnose, is that the spread of this pathogen is likely underestimated. So in this slide here, I'm just trying to show various ways that it can appear on chrome agar, that it's not always uniform. The first picture that you see on the left is a mixed culture with two other Candida species. And you can see just the one white colony circled in red is the Candida auris. In the middle image and then the image on the right, you can see that it varies in colors from white to pink to purple. Now we're going to move on a little bit and talk about Candida auris in the clinical setting. The axilla and the groin are the highest yield sites for colonization, followed by the nares. Other colonization sites include urine, stool, the vagina, and rectum. And patients with a clinical infection are typically found to be colonized in non-invasive sites as well. Similar to many organisms that we see, an individual that is colonized, even if they don't have an active infection, can be a source of transmission. And it has been shown that this colonization can occur rapidly within just a few hours or a few days from exposure. Once a patient is colonized, they can then develop an invasive bloodstream infection within days to months. Candida auris also has a unique ability to evade the host's innate immunity. One study showed that not only do human neutrophils fail to effectively kill the organism, but they also fail to form structures which are used to entrap the organisms. So how do you do surveillance for a clinical case? It's important to know what to do if you identify a clinical case, and then how to perform surveillance in the rest of your facility or just the unit. Cases should immediately be reported to the state or local health department and to the CDC. You not only need to do this so that they have their own for their own tracking purposes, but they're also a really good resource to help guide you with your next steps and your plan in your facility, especially if this is the first time you have seen this. Candida auris should be considered with an increase in unidentified Candida on patient care units. And this would also be another time to go back and talk to your lab about identifying to the species level. If a case is identified, past microbiology records should be reviewed, as far back as 2015 if possible. Again, another time to have a discussion with your laboratory. If they didn't have the ability to identify C. auris, there could have been a possibility that it was misidentified. Just as we know surveillance for clinical cases is important, it's important to have a plan or an understanding of how to do surveillance for colonization. Some situations when surveillance screening should be considered are when you have close healthcare contacts of newly identified Candida auris infection or colonization patients. At the very minimum, you would want to screen roommates that were with the patient within the last month. Another time would be patients who have had an overnight stay in a healthcare facility outside of the United States within the previous year, especially in a country with documented Candida auris, which we saw is about 25% of countries. Screening can also be done if there is a suspicion of ongoing transmission, and the recommended screening method is to perform a swab of the patient's bilateral axilla and groin. It's important to note that the same infection control precautions should be used in patients with colonization and infection. And we're going to discuss the specifics of this in the upcoming slides. So let's move on to prevention. Not only prevention of a case, but prevention of spreading it throughout the facility or the unit. As with everything else in infection control and healthcare, you can never reinforce hand hygiene enough. Alcohol-based hand sanitizers are effective against C. auris, and it is the preferred method if hands are not visibly soiled. Once a case or colonization is identified, transmission-based precautions should be put in place based on the setting. And we're going to go over this more in detail in the next slide. When preparing your facility's plan, it's a good idea to preemptively plan for what disinfectant you're going to use. Check and see if a disinfectant you already have in your facility has a kill claim against C. auris. This would be the easiest way to switch over if you have a case identified. You also need to make sure you double check the dwell time for that disinfectant because it can differ between organisms. On this slide, I've included 2 links for your use to access resources on appropriate disinfectants. First, we have the Environmental Protection Agency's List P, which is a list of products specifically that have a kill claim against Candida auris. And if those products aren't accessible or otherwise suitable, there is interim guidance that's still in place that would permit the use of an EPA-registered disinfectant, which is effective against C. difficile spores. An important part of source control is communicating between facilities for any known patient or resident with an infection or colonization if they're being transferred. We also want to try to contain the spread within a facility or a unit of newly identified patient contacts, so we would want to screen them. And then last, routine laboratory surveillance in a facility that has a new case identified. Prospective surveillance should be used to identify other cases. And then we should be speciating it for any Candida specimens, regardless of where they come from, for at least 1 month until there's no evidence of transmission. To emphasize the proper use of disinfectants, I want to talk through an outbreak that occurred in the United Kingdom. Now, this outbreak took place between February 2015 and August of 2017. There was a total of 70 patients identified as being colonized or infected, and of these, 66 cases, or 94%, had been admitted to their neurosciences ICU before their diagnosis. In response to the cases, they started routine screening beginning in October of 2016. This involved screening on admission to the ICU. They did weekly screening and then screening on discharge. With this screening, they swabbed from the nose, axilla, groin, tracheostomy if present, wounds, and they took a urine culture. They actually then increased the frequency of screening to 3 times per week for the axilla and the groin in 2017 because they were trying to detect colonization earlier. In addition, they used various methods to do environmental screening, focusing on high-touch areas and reusable devices. And when they looked at these cases, they determined that it was likely linked to reusable axillary temperature probes. The probes were being properly cleaned between patients using a wipe that had quaternary ammonia compound Although the probes were really difficult to clean because the way that they were built, they had a 2-layer rubber sheath on the end to protect it. And then unfortunately, since then, it's been shown that quaternary ammonia compounds have relatively poor activity against all Candida species. So their data showed that the use of these axillary temperature probes increased the odds of C. auris colonization or infection by a factor of 6.8, and they were used in 86% of the cases they identified. So obviously there is no way for us to know how an effective disinfectant would have impacted the trajectory of this outbreak, but it certainly could have limited the spread. So like I stated in the previous slide, isolation may differ based on what sort of healthcare setting you're in. In acute care hospitals and long-term acute care hospitals, the patient or resident should be placed on contact precautions. In nursing homes, including skilled nursing facilities with ventilators in use, contact precautions or enhanced barrier precautions should be put in place. The patient or resident should be placed in a single room whenever possible, and if you can't do a single room, then you should only cohort patients with the same MDRO and keep patients separated by at least 3 feet. And we need to continue these transmission-based precautions for the duration of the patient's stay within the healthcare facility. So I want to go over enhanced barrier precautions in a bit more detail since it is a new isolation category from the CDC, which was put out specifically for long-term care. It's understood that contact precautions in these environments aren't always feasible, but it's still important to prevent the spread of MDROs. We just know that this is hard in these situations because this is essentially these residents' homes. Enhanced barrier precautions kind of fall somewhere between what we know of standard precautions and contact precautions. It requires a gown and gloves for certain residents during specific high contact care activities that have been found to increase the risk of MDRO transmission. It is very important to note here that this does not apply in the acute care setting. This is specifically for long-term care. And this does not replace contact precautions for other pathogens such as C. diff or norovirus. Enhanced barrier precautions expands the use of PPE for situations with exposure to blood and body fluids, as we do commonly for standard precautions, but it requires the additional use of gown and gloves during high contact resident care activities. These are activities that have been identified as opportunities to transfer organisms to staff's hands and clothing. 2 situations where this applies is infection or colonization in a resident with a novel or targeted MDRO when contact isolation isn't feasible, or a resident with a wound or indwelling medical device regardless of their MDRO colonization status if they reside on a unit where there's another resident known to be infected with one of these targeted MDROs. An example of high contact resident care activities which require the addition of a gown and gloves are dressing, bathing or showering, transferring, providing hygiene, changing linen, changing briefs, or assisting with toileting. Also, if you're doing any sort of device care or use, such as with central lines, catheters, feeding tubes, or ventilators. And then also preparing for wound care for any skin opening that requires a dressing. As with any sort of isolation, you can always increase your PPE usage. So if there's a risk of a splash or a spray, face protection would also be used. On this slide, I provided a link to a free webinar from the CDC on enhanced barrier precautions, if you would find it useful for you or your staff to go over in more detail. Along with educating your clinical staff, we always want to make sure to educate our environmental services. They have a really big impact in decreasing bioburden using disinfectant products, and it's important for them to recognize that how important their role is. We need to let them know that C. auris can be shed into the environment by infected and colonized individuals, and it can easily spread. Environmental sampling has found that organisms in several places in patient rooms and hallways outside of their rooms. It's been found in beds, chairs, windowsills, countertops, ECG leads, blood pressure cuffs, infusion pumps, temperature probes, and ventilators. So pretty much everywhere in the patient care area. And testing has shown just how resilient this organism is. It can persist in the environment for several weeks. In laboratory studies, it's been shown to survive on moist surfaces for at least 7 days, on dry linen for 7 days, on dry steel for at least 7 days, and then also dry plastic for at least 14 days. And just think about how much plastic there is in patient care areas. So for it to persist for 14 days is important. Daily and terminal cleaning with an EPA-approved disinfectant is necessary to mitigate the risk. So we need to ensure staff are educated to clean with whatever your facility designates as your disinfectant from those 2 EPA lists, either EPA list P or K. At a minimum, the daily cleaning must include high-touch surfaces, and unfortunately, evidence has shown that UV light is not effective against C. auris. To piggyback off of this information, I want to go over another report of an outbreak. This outbreak was with 50 cases. It was ongoing at the time of the report, and it was a 16-month time frame from April 2015 to July 2016 in a London facility. The first case is identified from a sternal wound in a mixed medical surgical adult ICU in a specialist cardiothoracic center. Within 1 week, they found a second patient who was positive in their sputum, and then this patient went on to develop an intravascular line-related infection. The second patient was in the bed adjacent to the index case. They had a little bit of a lull, and then 1 month later, they identified 2 more patients in the ICU to be carrying C. auris. When they performed environmental sampling of the clinical area around the colonized patients, they found contamination on horizontal surfaces such as the floor around the beds, trolleys, radiators, windowsills, equipment monitors, and keypads. They did also identify it in 1 air sample. They also went a step further and they screened staff for colonization by culturing their hands, nose, axilla, groin, and throats. They screened 258 healthcare workers, but only 1 nose swab was found to be positive. The particular nurse that this swab came from had been caring for one of their heavily colonized patients, but they were not caring for any other previous or subsequent cases, so they determined that this person was an unlikely source for the outbreak. The conclusion from the authors was that survival in the environment appeared to facilitate the persistence and transmission of this organism. And the results indicated that reusable patient equipment may have served as a source of infection. So when you hear people say that environmental services are part of the infection control, this is exactly what they're talking about. From an infection control standpoint, treating Candida auris is much like any other MDRO. Obviously, we want to consult with an infectious disease specialist. They are the experts, of course. And then, as discussed earlier, patients often remain colonized for long periods of time after treatment, so infection control measures should be maintained during and after treatment. We know that organisms develop resistance quickly, therefore patients should be monitored for clinical improvement with follow-up cultures and repeat susceptibility testing. Historically, it has been documented that recurrent and persistent Candida auris bloodstream infections have happened. With every other colonization, it's not recommended to treat Candida auris from non-invasive sites if there's no evidence of an active infection. Some of these sites would be the respiratory tract, urine, and skin colonization. But regardless of treatment is initiated, we want to keep the infection control measures for all patients identified with C. auris. So we have covered a lot of information, and what we want to do now is just a few polling questions to really stress the impact of some of these things. So the first one is all of the following except what differentiates C. auris from other Candida species. And these different characteristics of Candida auris are important for everyone to keep in mind. When we as IPs think of organisms, we think of them in terms of groups when we're doing surveillance work or working up an infection. Knowing that Candida has key differences from other species will allow you to think outside of the box or throw up red flags maybe earlier in the process if you're seeing an increase in specimens, especially with an emerging pathogen when clinicians might not be aware or thinking about Candida auris as a possibility. So these are things that we as infection preventionists can really do to help as part of the care team. So we have here, right, we have 54% of people got the answer correct. It's the ability to colonize the GI tract, which is not something that we see in Candida auris, which actually makes sense if you think about and remember that it does not grow well in an anaerobic environment. And our second question here should be coming up soon. This is, which of the following groups is not at an increased risk for Candida auris? So just like knowing specifics about this organism, it's important to know who the high-risk groups are, and do you have that patient population in your facility? So not only does this impact who we should screen, but it also acts as clues for when you're reviewing surveillance cultures, and when we're thinking about times it may be important to speciate results. This is just good information to keep in the back of your mind as you go through your daily routines when you're looking at your surveillance or when you see an increase in cultures. And we should have those results coming up soon. All right, very good. This time we have 76% of people guessed correctly C, which is patients under 10 years old. And so that is the wrong answer because Candida auris infections have been seen in people of all ages. And our last question. All of the following are key prevention tools for Candida auris, except which one of these following? So we want to really make sure that we review the prevention tools that we've gone over. How many do you have implemented already, or there may be some areas where you could do a little bit of work? Not to give away any answers, but I think this one is obvious. You would want to look at your hand hygiene program. Do you have a good monitoring system in place to know how well each unit performs? And if you do have a program in place, what do you do if your response, if they fall below compliance rates? How do you get those units to correct their course? There's no point in really having a surveillance program if you don't have a good way to correct course if they fall. Okay, 65%, good job, got D, EPA disinfectant, which is effective against CRE. And this is incorrect because it should be a disinfectant, which is effective against C. diff. So now going over a scenario. Suppose you come into work and you find out that you are receiving a transfer from a local rehabilitation facility with a known history of multiple acute care stays, diabetes, and a recent history of a wound infection and sepsis following a below-the-knee amputation. You're aware that the rehab facility this patient's coming from had a known Candida auris case, and you have a basic understanding with the risks of this organism, which hopefully you'll have after the presentation today. So you want to be proactive in preventing any cases within your organization. So what do you need to think about? What does your plan need to be? Do your policies reflect appropriate practices for the prevention of Candida auris? Do you know if your laboratory can identify it, and have they been identifying it? Should you evaluate for colonization and/or infection? And if so, do you want to collect sterile specimens? Are your cleaning and disinfection products effective at killing C. auris? And do you have identified what you're going to use if your normal disinfection product doesn't have a kill claim? If a resident is colonized or infected, what are the best practices to prevent transmission? Some things you want to think about would be dedicated patient care equipment and implementing transmission-based precautions. Have you emphasized hand hygiene with your staff and the use of sporicidal point-of-care wipes? And then do you want to collaborate with the healthcare team to identify, treat, and manage the care? So this is kind of a good working list to start thinking about this if you know that you have a patient coming in who is colonized or is at high risk based on the facility that they're coming from. So to wrap up the presentation, I wanted to present some resources. As always, the CDC has numerous resources available online, such as fact sheets, information for patients, laboratory staff, infection preventionists, and public health professionals. And these are really great resources when you're trying to educate staff. In addition, the Pennsylvania Department of Health just recently published a C. auris toolkit that's available online. This is a really great resource for additional materials. I looked through it a bit yesterday, and it contains various templates such as scripts for colonization, screening, and transfer letters. And then they also have step-by-step guides for swab collection, for patient screening, and a list of common scenarios where you might see the misidentification of Candida auris. And there is a link on this slide so that you can access this resource. And then, of course, you always have the 3 IPs at the Patient Safety Authority, Joanne, Christine, and myself to use as a resource. We're always here and available for you. This slide includes all of our contact information. And Joanne, I will turn it back over to you.
Thank you, Amanda. Excellent presentation. Now I would like to introduce our guest speaker. Dr. Kara Bicking-Kinsey is an epidemiologist working on the healthcare-associated infection prevention in the Bureau of Epidemiology for the Pennsylvania Department of Health. Her expertise is in outbreak investigations and infection prevention and control. Kara, would you like to add to the presentation?
Thank you, Joanne. Amanda, thanks for the presentation. I thought it was awesome. There are so many questions about Candida auris that remain unanswered. But the only thing I really thought to add was there was a lot of information about disinfection and using a List P disinfectant. And I think that if your facility is in a place to not know what you want to have on deck in terms of a disinfectant product for Candida auris, say you haven't had Candida auris yet and you're using routinely something that wouldn't work against Candida auris, my HAI outbreak program has actually developed a training. It's about 24 minutes long. On how to choose an effective EPA registered disinfectant. I don't know about you, but I find the EPA lists not very self-explanatory. So if you go to pa.train.org, you can look in there for lots of trainings, but the EPA registered disinfectant training is in there. And we're also planning a lot of work to create more educational materials around Candida auris.
Thank you both, Amanda and Dr. Bicking-Kinsey. That concludes the slide presentation portion of our program, and now we would like to begin our question and answer period. So we do have a question. Should staff be tested as part of an outbreak investigation?
So from what I have seen, staff are not usually included as part of an outbreak investigation just because they're not usually found as reservoirs. It's most commonly found in people who have immunocompromising conditions or things that make them more at high risk, which we don't usually see with our staff. We're usually more concerned about environmental risks. But as the one outbreak that I did go over, they did do staff really just trying to cover all their bases. I think this is something that's really a case-by-case question and would be good to consult with the public health department as a good guideline for what to do in your specific case.
Thank you, Amanda. And we have another question. Is an outbreak checklist available if a facility does identify a case of C. auris?
This is Kara. So, my team at the Department of Health and the Bureau of Epidemiology, we are really tasked with walking through outbreak response with you. And at this point in our Candida auris journey, we do that for every single case that's identified in Pennsylvania, if we're your local health department. So we do have a checklist. What we do is we provide you detailed recommendations over the phone. We have conversations with you. We make sure you understand all of the recommendations. And then we also have the materials in the toolkit which would supplement our conversations. And in there, we have basic recommendations, and then when we work with you, we also provide a more extensive checklist of recommendations.
Thank you, Kara. We have another question in the chat box. Should residents be isolated while awaiting the lab results?
So for this one, I would defer to Kara and her team, but I would say that yes, we should. For organisms that are so important and can spread so easily, I think it would make sense to preemptively isolate when you're waiting for these results. And then if they come back negative, you can take them off of isolation.
Yeah, I'll add that I think it depends on the purpose. So if you have, I think the question comes from a place of screening somebody who you believe is high risk for Candida auris. Maybe they had a healthcare exposure, were in the same room with another patient who became positive or something like that. Then Amanda's right. We would want to have contact precautions in place until the results came back. But if you were doing, we have outbreak response where we'll do what we call point prevalence screening. And we do screening tests on everyone in the whole unit, for example. And in those cases, we don't usually recommend contact precautions for everyone. So it depends on the situation a little bit.
Thank you, ladies. We do have another question. What should be my first step in developing a C. auris plan at my facility?
I'm not sure if I would say there is one definite first step, but I think that one of the important things that should be done first would be to talk to the lab and find out what your laboratory's ability is in identifying Candida auris, if they're able to do that. And if not, is that something that they can get on board, or does the technology that they have, is it just not available? I think that's one of the most important first things to look into.
I totally agree, because it all depends on what your laboratory can tell you. But also because there is no one first step, right? I think making sure that you sit down with the medical director, infection prevention, and really anybody who has decision-making ability, and make sure they understand what Candida auris is and why you need to be prepared. I think that will get you a long way to having something in place eventually.
Another thing too, I think is important, and obviously this can't be your first step, but I find it's commonly one of the last steps, and maybe is something that we want to institute a little bit earlier, is educating staff. I think unless they are in an infectious disease physician, it's very likely that a lot of our clinicians have not heard of this organism. It's not in the forefront of their mind. They're just not thinking about it. So I think any opportunity that you can to get education out to your staff and reinforce that is important.
Thank you. The webinar will soon be ending, but we do have time for a few more questions before we end the program. So if you do have a question, please type it into the Q&A box. Do either of you ladies have any final comments?
Joanne, there's a few questions in the Q&A and also in the chat.
Okay, I didn't look in the chat. Okay. Do you recommend having a separate policy and procedure for C. auris, or is it acceptable to add the plans into the transmission-based precaution policy?
In facilities that I have worked in, we have had separate plans. I think that because it's an emerging pathogen and it's something new, it's not a bad idea to have a separate policy. But if you think that you can cover it in your general transmission-based precautions policy, then I think that's okay to do too. I don't think there's a right or a wrong, as long as you make sure you have all of the information there.
And here we have another question. C. auris has been misidentified as C, and excuse my pronunciation, hemuloni. Has the MALDI database been updated? And any guidance for misidentification from the lab?
So I do know that it is available in the database. It's just whether or not that is on in your specific, if your specific lab has been updated. So it is available, but you would have to check with your specific lab to make sure that it does have that in your instrument.
And Kara, do you have anything to add?
Yeah, I was just going to say that there are CDC's website. If you just type like C. auris CDC into Google, and they have a section on their website for laboratorians that also talks about specifically identification. So it lists, like, if you have the Bruker biotyper, MALDI-TOF, and you have the library version 4, or you have any of their research libraries, that has the Candida auris detection ability. And then, so, and it lists different brands and the exact library. So if you are a laboratorian, you can cross-reference that. Or if your laboratory just doesn't know for sure, they should reach out to their vendor. CDC list, common misidentifications. And Joanne, you didn't do bad. As Candida hemalonii.
Thank you.
You were close. Candida hemalonii is one of the common mis-IDs. And we ask that those be reported to the Department of Health so that we can investigate further. But more and more libraries are fixing that issue and able to detect Candida auris. So it's becoming a smaller issue as we move forward. But I think that's why Amanda's point about talking with your lab is really important, because they might not have seen the need to update a library, for example, and you can give them a good reason to, perhaps.
I'm also always in favor of communicating with the lab as much as possible. I think having a good relationship with your lab as an infection preventionist is really important. Sometimes then you just get phone calls about, hey, I'm seeing this. Have you recognized it? So I think keeping those lines of communication is always beneficial for various reasons.
Thank you, ladies. Then we will conclude our webinar. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.